Today we're going to go over Chapter 15, the urinary system. Okay, so I'm going to tell you a little story. The very first time I moved to Hawaii, I had a student who said, "Oh, miss, I need to go shishi." I'm like, what is shishi? Is that a type of sushi or something? And then started laughing at me because no, I guess it's the local way of saying that you need to use the restroom. Okay, so when we talk about using the restroom going shishi, we're talking about the urinary system. And so a couple of functions for this urinary system is elimination of waste products. We know this as nitrogenous waste, toxins, and drugs. We can regulate plasma ion levels in the form of electrolytes. You remember that sodium and also that potassium, those hormones regulating our kidneys, the excretion of the sodium and this potassium. And of course, if we regulate whether we're going to excrete or retain these ions, we can then in turn regulate blood volume and blood pressure. You remember water is always going to follow wherever there's a high solute concentration. And so let's say we're going to retain sodium in our body. Where's water going to go? Water is also going to stay here within our body. That in turn is going to increase our blood volume, which in turn increases our blood pressure. Another function of this urinary system is to stabilize blood pH, and we can do this by acid-base balance. So there's 3 different systems we're going to look at later on. And then we have stimulation of red blood cell production. You remember from chapter 10, anytime we have a decrease in oxygen intake into your body, we can increase the amount of red blood cell production by the release of erythropoietin from our kidneys into our blood. And that's going to stimulate more of those red blood cells to grow and divide. And we can then increase the amount of red blood cells in our body. Finally, we have the activation of vitamin D. So vitamin D is inactive within our skin, and then it's going to finally have its activated form within our kidneys. Let's look at the different organs of the urinary system. We first have our kidneys. This is where we're going to filter our blood and then produce urine. Ureters, these are going to transport all that urine towards the urinary bladder. And this urinary bladder serves as a temporary storage tank for all that urine before we excrete it out through the urethra. Okay, start off with this first organ of the urinary system being the kidney. And it's located against the dorsal body wall in a retroperitoneal position. Meaning, remember here, our abdominal cavity is enclosed, so it's called a peritoneum. And if you cut someone open, you're not going to see your kidney. So retroperitoneal, meaning it's behind that peritoneum. And so you'd have to remove that peritoneum, and then you'll see that kidney exposed. And for those of you taking your Bio 130 labs in this fall or next year, you're going to see these kidneys in your fetal pig dissection. So key that it's located retroperitoneally. Okay, so it's behind that parietal peritoneum. Oh, I should put behind. Behind, right over there. Now, another thing is this right kidney, if you notice over here, it's slightly lower than the left. And why is that? What organ do you think can cause and account for this lower positioning of this kidney? Good, that liver. You remember our liver is actually going to start curving towards this direction. And so because of that, it's due to the position of the liver. Another thing we have here is this kidneys. It's at the level of the thoracic 12 to lumbar 3 vertebra. Okay. Let's look at a couple of kidney features. We have a couple of structures here. We have the renal hilum. And this renal hilum, this is where all of the ureters, both ureter, are going to enter into each of these kidneys. Also, we have our renal artery, in here in red, and renal vein. So renal artery entering into our kidney and renal vein exiting our kidney. And so this is that renal hilum is this, I'm going to put number 1 and come over down here. This is that medial indentation where structures enter or exit the kidney. What else do we have here? We have a couple other structures. Sitting right above our kidney, we have this gland. What was that gland again? Good, the adrenal gland. So we have that over here. And then also surrounding each of these kidneys, we have a fibrous capsule, which we call a renal capsule. Let's look at a cross-section of the kidney and look at the other internal regions. If we look at this, we can actually separate the kidney into three major regions. So if we're going to draw on this one over here. So this outermost layer here that I'm encircling, this is called the renal cortex. And remember, anytime you have an outer layer, that's always going to be the cortex. Middle is going to be the renal medulla. So this entire region over here is the renal medulla. And then finally, internal here, this is the renal pelvis. So that's the renal pelvis here. Now, what do we find here within this renal medulla? We have lots of structures that also you'll need to know and identify for your quiz. And so we first have this area here. It looks just like a pyramid. So we call it a renal pyramid. Between each of these renal pyramids, we have this longer structure here. This is called a renal column. And then finally, we have calyces. So we have a minor calyx over here, and we have a larger calyx over here. And what are the functions of these calyces? So this is actually where urine collects. Okay, so urine's going to first collect from our minor calyces, and input from two or more of these minor calyces are going to gather into the major calyx. Okay, and so if we look at here, all these renal pyramids, what's found on here are these smaller structures, and these are called nephrons and collecting ducts. And so this is really that filtration, means of filtration of our blood and within our kidneys. And those, both this lower descending loop and ascending loop, and also these collecting ducts, those are going to run along this entire renal pyramid. And once we can collect a lot of that urine that's going to enter here into this minor calyx, and both of this from here and here are going to enter into this major calyx. Now from here, where is that urine going to go? It's going to exit into this renal pelvis and then finally go down into our ureter. So urine eventually is going to leave our renal pelvis to the ureter. What's also interesting here is that we have 25% of the total blood supply of your body is going to pass through the kidney each minute. Pretty crazy, right? So lots of that blood pressure, filter out all that blood, get rid of a lot of those toxins, a lot of those solids. So very important for you to have your kidneys. Let's look at this blood flow, since we talked about this being that filtration system of your blood. We're going to start off here with our aorta. Of course, we have our descending aorta. It's going to go into our abdominal aorta. From here, we're going to enter our kidney through that renal artery. Remember, that's going to be that one specific artery entering into our kidney. From here, so here's our renal artery, we're going to branch off to form segmental artery. And segmental arteries, these are what you're going to find here within your pelvis. And then from here, we're going to enter into those renal columns, and these are going to be called interlobar arteries. So inter meaning between, and you can think about them being little lobes. So in between each of these lobes, so right over here is the interlobular arteries. And then finally, we're going to go to this arcuate artery. So arcuate, these are now found within the cortex. And these are going to be these arteries over here, right above those renal pyramids found within our cortex. From here, we're going to branch off into cortical radiate arteries. So those are these long arteries right over here. So right over here, these nice long projections into the cortex. So also found within the cortex. And then finally, we're going to have an afferent arteriole. Now these are going to be much smaller. And here are those afferent arterioles. And where all that filtration is going to occur are at these glomerulus capillaries. So only will filtration occur over here. We also have peritubular capillaries, which we're going to get into a little bit. But filtration, right over here. I'm going to highlight that because it's very important. Now from this glomerular capillaries, I'm just going to move to the next slide so we can see that. Here we have that arcuate arteries, cortical radiate arteries. This is what we see out here in our cortex, so cortical radiate arteries. And over here, this is that afferent arterial, which we see over here. So here's this afferent arterial. Then here we have those glomerular capillaries, which look just like a knot. So it's just a whole bunch of knotted capillary beds. Then from here, we're going to have the efferent arterial. So E is going away, A meaning to or toward. So afferent arterial is going towards our glomerular capillaries. Efferent arterial is going away from our glomerular capillaries. Now from here, what are we going to form? We're going to form what are called peritubular capillaries. And these peritubular capillaries are an extension, or they're going to form from this efferent arterial. And what that's going to do is going to surround the structural unit and functional unit of our kidneys called the nephrons. And so the nephrons is this creamish color, long tube that you see over here. And these peritubular capillaries are going to surround that. And we're going to see why that's so important. Before we get into the structure of the nephron, let's continue the blood flow. So from these peritubular capillaries, what are we going to form? We're going to form the cortical radiate vein. So now we're going to go back after you have those peritubular capillaries. We're going to come back in this direction. Here's that cortical radiate vein. Then we have the arcuate vein over here. Interlobar vein, so going back in this direction. Then we have the renal vein into the inferior vena cava. So that's how we're going to bring that back towards the heart. Now let's take a look at these nephrons, because these are the important structural and functional units of our entire kidney. And because it's so important, we have over 1 million in each kidney, right? Who's that? Austin Powers, $1 million. Okay, so function of these, this is going to be responsible for forming urine. And these nephrons are divided into two major regions. We have the glomerular or Bowman's capsule, two different terms for that. That's everything here that you see in beige. And then the second region we have is the renal tubule, and that's over here. And the function of this renal tubule is designed for that reabsorption of a lot of nutrients, and we can also deposit more waste and toxins if needed before we release everything out as urine. So two regions once again. Glomerular capsule, also known as Bowman's capsule, and renal tubule. Let's go over the function first of this Bowman's capsule. Bowman's capsule, here's a better illustration of that, being this internal space all over here. And what's inside of that, and deeper to this, we have those glomerular capillary beds that we saw earlier. We had that afferent arterial leading to this, and then we had that efferent arterial coming out. Now, if we combine both this entire region, both that glomerular capillary bed and this glomerular capsular space, this is collectively called the renal corpuscle. Okay, so sometimes you might see that in your textbook, and that's really what that is. Now we're going to take a closer look of what's deeper to this Bowman's capsule, being this glomerulus. And what you're going to notice is that this glomerulus, that's only that capillary bed. But found inside of this glomerular capillary space, or this glomerulus, we're going to have, it's going to be covered with these cells called podocytes. Everything here that you see in yellow, these are those podocytes. And what they have are filtration slits that allows all of this solutes and filtrate to exit from our afferent arterial, we have into this glomerular capillaries, into our glomerular capillary space. I'm going to clean this out really quick, and I want you to understand that what's going to drive this, just like our heart, remember from our heart, as we go deeper towards our arteries and our arterioles and our capillaries, what forces things out into our capillaries? It's going to be that blood pressure. Same thing here, blood pressure is going to force fluid and solutes out of our blood and into this glomerular capillary space. And these podocytes are going to allow substances that are small enough to fit in through these slits into this glomerulocapillary space. So blood pressure is going to force out fluid and solutes from that afferent arterial, or that glomerulocapillary, into that glomerular capsular space. Okay? And what do we expect not to go through? Well, we don't want any red blood cells. Red blood cells are too large to fit through. We also don't want any of those plasma proteins. Remember albumin, and also those clotting factors. We don't want that getting through here. So red blood cells and albumin. Typically, those are proteins that are too large to fit through all these filtration slits. Now, let's say that you do have a urinary tract infection. You have infection here at this glomerulocapsular space. And what can happen? That can allow red blood cells to come through, and sometimes you can see blood in your urine. Okay? So make sure that you understand, most importantly, high blood pressure is going to force out that fluid and solutes here into this glomerulocapsular space. And so what we're left off with fluid, what this is called filtrate. So it's important to note that filtrate contains both good and bad solutes. Okay, so we can have urea, we can have sodium, potassium, but we can also, so both of those are going to either be good or bad. Here's a closer look of those podocytes. And remember, here's podocytes covering our entire glomerulus. Here are those foot processes of those podocytes that are small enough to allow small substances and solutes through. Now let's go over the renal tubule. And because this renal tubule is so long, we give different terminology depending on where that renal tubule is and whether or not it's going to be absorbing or secreting substances within it to form that urine. So we have the very first region of the renal tubule, and that's going to be the proximal convoluted tubule. So that's going to be this region over here, proximal convoluted tubule. Is the tubule that's the closest to this capsule, the glomerular capsule. So the very first region. Next we have what's called the loop of Henle. So loop of Henle is going to descend down. We see it going down over here. And loop of Henle also goes up. So we have this descending branch. I'm going to make a note, number 2, to come down here. So we have the descending arm of the loop of Henle. And we have the ascending, so going back up, arm of the loop of Henle. And then from here, we're going to form the distal convoluted tubule. So here's that distal convoluted tubule over here. And then from here, anything that's left over, we're going to bring into the collecting duct. So this is that collecting duct. And the collecting duct, we can also have more reabsorption of water or solutes within this area. Anything left over from this collecting duct is going to empty out into our renal pelvis and then get excreted as urine. So here is going to be the collecting duct. Collecting duct is going to receive urine from many nephrons, as you can see over here. We have extensions that is going to lead to all those distal convoluted tubules. This collecting duct, this is going to run through the medullary pyramids. You remember here are those medullary pyramids, and those were those collecting ducts. So a lot of them are going to run through here. Then it's going to deliver that urine into, what's that next structure we mentioned earlier? The minor calyx, and then the major calyx. So it's going to deliver into the calyces. And then finally out through that renal pelvis. From here, this renal pelvis, we're going to exit out into the ureter. Good. Now there's two different types of nephrons that we have, and we can see them here. So we have the cortical nephrons, and these comprise majority of the nephrons that we have within our kidneys. And as you can see here, here's that corpuscle, that Bowman's capsule. Here we have that proximal convoluted tubule. Here we have that loop of Henle. Then we have the distal convoluted tubule before we end up here at this collecting duct. And so cortical nephrons, just like the name, they're going to be found here within our cortex. Then we have juxtamedullary nephrons. And these are going to extend between the cortex and the medulla. Okay, so most of them are going to be the cortical nephrons. Let's take a closer look at this nephron anatomy. And as I mentioned earlier, we have two major capillary beds. And this is where a lot of students get kind of confused because they wonder, well, where are those capillaries going and where are these arteries and veins coming in and out of this entire nephron? And so you think about this capillary bed and the nephron as two separate entities. So here we have this afferent arteriole coming in. Remember, we have high blood pressure forcing out all of those solutes and liquids, so it's going to be both good and bad things, into our renal corpuscle, so we're going to, or into our Bowman's capsule. So we're going to collect that all here, and then all that blood supply is going to go back to this efferent arteriole. It's then going to form into peritubular capillary, so here's our first capillary bed, being with this glomerular capillaries. Second capillary bed are these peritubular capillaries. And these peritubular capillaries are going to surround our proximal, our distal convoluted tubules, as well as our loop of Henle. And why is that? It's because this peritubular capillaries, this is going to allow for us to reabsorb a lot of that water that was filtered out into our capsule, and we can also put back in some other toxins that were not removed in the very first time within our blood. And so here we have the peritubular capillaries surrounding, we're just to say, this loop of Henle. Then from here, we're going to have this vein. So remember that vein is going to go back to that cortical radiate vein into our arcuate vein. Okay, so that's where that all comes in. And so let's write that one more time. Glomerulus. Found within that Bowman's capsule. And then we have the peritubular capillaries. Okay, let's go over this glomerulus one more time. So we're going to feed, it's going to be fed and drained by arterioles. Afferent arteriole, it's going to arise from which artery again? The radiate artery. This is going to go into our glomerular capillaries. Then we have the efferent arteriole. It's going to receive all that blood that has passed through the glomerulus already, and it's then going to go back towards those peritubular capillaries. And so, very important, this glomerulus is specialized for filtration. And also, possible exam question, anytime you see blood within your urine, it could be problematic right over here at this glomerulus, so you know it has something to do with filtration. Relationship to blood pressure, once again, we said earlier, if we have an increase in blood pressure, we're going to use that blood pressure to filter out our blood to form that urine. So increases filtration of urine through that glomerular capillaries. Peritubular capillaries, this arises from those efferent arterioles. They're located, where are they located one more time? Surrounding the entire renal tubule. It works under normal low pressure, meaning that we're not going to force out, all these capillaries are not going to force anything out into our tubule any longer, nor are we going to collect things actively from our tubule into our capillaries. And all of this movement is going to be by endocytosis or exocytosis. And we're adapted for reabsorption, or we have secretion, so reabsorption deals with taking back in lots of that water from our renal tubule into our capillaries. Secretion is moving from our capillaries into our renal tubule. So reabsorption, let's just make a quick note so you're not confused. This is movement of solutes and liquids from our renal tubule into our capillaries, our peritubular capillaries. Secretion is movement of waste and solutes and toxins from our capillaries into the renal tubule. The way that we form urine occurs under 3 different steps. We have that glomerular filtration, tubular reabsorption, and then finally tubular secretion. And what's remaining is what we give rise to urine. First step of urine formation, we have glomerular filtration, and this is a non-selective, passive process. And usually, what did we say was too large to fit through? Good. So we had proteins and blood cells. So both red and white blood cells are too large to fit through that filtration membrane. And that filtrate is collected in the glomerular capsule and leaves via the renal tubule. Okay, so here's a cortical radiate artery, afferent arterial, and here's a nice illustration of the different arteries. Glomerular capillaries over here, and we have the efferent arterial. Then here we have that glomerular capsule surrounding our glomerular capillaries. Second phase we have is tubular reabsorption, and this is when the peritubular capillaries are going to reabsorb useful substances. So we have the water, glucose, amino acids, and ions, which you see over here. So lots of this red means reabsorption. So active transport, active reabsorption of these substances, so sodium chloride, we have bicarbonates, water, glucose, and amino acids coming back into our peritubular capillaries. Okay, so some of that reabsorption is going to be passive, specifically water. However, most of it is going to be active, and that's going to be specifically a lot of these larger solutes like glucose and amino acids. Okay. Compensation and location, the majority of the reabsorption, where is that going to be? In here, this proximal convoluted tubule. We also have tubular reabsorption in this distal tubule over here. So sodium chlorides coming back in. Here within this loop of Henle, we also have reabsorption. Here in this descending arm, we only can have reabsorption of water. That's key. In this ascending limb, we can only have reabsorption of sodium chloride. So here you have no water in this ascending limb. Same thing here in this descending limb, you have no reabsorption of sodium chloride. So these are very important to know as well. Now what else do we have? What is not reabsorbed? We do not have reabsorption of a lot of these poisons and drugs and toxins back into our body. And we don't have reabsorption of urea. And urea, this is a breakdown from protein. So it's a byproduct and waste product of protein. Other things that were not reabsorbed, so we have uric acid. This is from the breakdown of nucleic acids, the metabolism of those nucleic acids. And then we have creatinine. So creatinine. Do you remember where creatinine was from? Good. From that breakdown of metabolism within those muscles. Remember we broke down the creatine. Okay, so some solutes that are not reabsorbed. Next step of your information is tubular secretion. So this is putting things within our blood into our renal tubule, which did not get secreted the very first time around. So movement of materials from the blood into the peritubular capillary, into the renal tubules. And all this material left in the renal tubule was going to move towards the ureter. So here we have drugs and poisons that is secreted back into our proximal convoluted tubule. Hydrogen ions, if we want to regulate our pH, we can do that over here as well. Potassium and drugs, so potassium also helping regulate our blood pressure, and then of course our blood volume. We can have also potassium in here secreted into our collecting duct. Okay. So lots of things that we did not already get rid of the first time within our filtrate. Now, what else do we see here? We have kidney stones, renal caliculi, also known as kidney stones. And this can occur if your urine is extremely concentrated. And solutes, specifically uric, form crystals that are going to precipitate in your renal pelvis. And this is what happens over time. It forms this solid precipitate. And it's going to be very painful when they're going to pass through that ureter. So here, I guess a great example, right? So if you have something protruding like this into your kidney, really painful. A lot of people who have kidney stones are going to have back pain. Because remember, these ureters and the kidney, they're going to lie retroperitoneal, so you can feel it going down your back. How do you treat this? We can use surgery. So if it's especially large, you can excise it. Ultrasound waves to shatter the caliculi. That's another means of breaking this down. So, ultrasound waves to shatter. And also you have surgery. And also treatment, well, let's just think about prevention in the very first place. You want to make sure that you drink lots of water to prevent the buildup of all of this uric within your renal pelvis. So very important, try not to skip out on water. Make sure you drink lots of water throughout the entire day to filter out your kidneys and prevent the buildup of this precipitate. Now, I have a friend who says she gets kidney stones quite often, and I was hoping that, too bad we don't have lecture, but she gave me some of her kidney stones to show in class. But maybe in the future, if you take lab, then we can also see these kidney stones if you haven't had them yourself, which hopefully you haven't. Okay, so let's look at this kidney characteristics of urine. In 24 hours, about 1 to 1.8 1.8 liters of urine are going to be produced, and it's yellow in color. And why is that? It's actually from something called urochrome. And urochrome this color results from the destruction of hemoglobin, so your red blood cells. So all that hemoglobin found within your red blood cells and solutes. And so of course, if you have a darker, deeper yellow color, this is when you have more solutes within your urine. And a dilute urine is pale and straw in color, so meaning you have more water within your urine. So of course you want to try to aim to have more pale urine to prevent all of those precipitate to form, that uric precipitate to form, and the buildup of those kidney stones. What's also interesting about urine is that it's sterile, meaning that you can drink it. And what gives rise to the non-sterility is the bacteria that grow around and surrounding your urethra. So urine itself actually is sterile. It's also slightly aromatic, and it's from the ammonia over time because of bacteria. So smell from that bacteria. Normal pH of your urine is around 6. And we also have this other characteristic of urine called specific gravity, which is considered like the weight of the urine in relation to water. And so it's the more dense your urine is going to be, that can signal you have more solids within your urine. And the lighter it is, if it's more comparable to water, that's going to be the more pale, so it's more dilute urine. And so specific gravity of urine typically is 1.001 to 1.035. Other characteristics. So let's go over some terminology, being urine versus filtrate. So you remember urine, this is what we're left with, and this is what's released and excreted by the body. So this is excreted by the body, and this is what's left over, whatever is left over, and leaves the collecting duct. So you can think about the collecting duct being the very last way to reabsorb anything and also secrete anything into our collecting duct before we form urine. Filtrate is very different. So we can think of urine as containing only the waste products. So strictly waste. Filtrate, this contains both good and bad solutes or products. Because remember, a lot of that peritubular capillaries and our renal tubules are going to be designed to secrete and also reabsorb a lot of that good stuff back into our blood. Okay, so this is going to contain filtrate. It's going to contain everything that blood plasma has except for those proteins and blood cells. And then urine is what remains after the filtrate has lost most of its water, nutrients, and necessary ions through that reabsorption. If we look at other characteristics of urine, so here's that filtrate. This is what's going to enter into our glomerulus. So we have lots of that water. We have proteins, sodium ions, chloride ions, bicarbonates, glucose, urea, potassium, uric acid, and creatinine. What's reabsorbed? Of course, we don't want to get rid of all that water. We also need to maintain our blood volume and blood pressure, as well as keep ourselves hydrated. So we're going to reabsorb a lot of that back into our body. Proteins, we don't want to have that go to waste, so we're going to reabsorb a lot of that back into our peritubular capillaries. Sodium ions, we need to maintain our blood volume, blood pressure. Oops. Chloride ions, also reabsorb a lot of that back into our body. Bicarbonates. Glucose, we never want to get rid of that glucose, right? It's that energy source for our body. Urea, waste products. Potassium and uric acid, a lot of that's going to be waste. So here what we see is that difference between what's filtered and reabsorbed, and that's going to form our urine. So urine, we have some of that water in here, and of course we're going to have lots of that urea because it's that waste product. Now, what if we see glucose within our urine, right? We said that glucose shouldn't be found, but what if we do see it? What can that signal? So, of course, not just glucose, but other substances that we shouldn't expect to see. These can signal different conditions or abnormalities of our filtration system. So, if we see glucose, this is called glucosuria, and this can signal having excessive sugar intake or also diabetes mellitus, so the inability of our body to actually store that glucose. Proteins within our urine, this is proteinuria. This is if you have physical exertion, if you're pregnant. Glomerulonephritis, so inflammation or an infection of your glomerulus. That can also cause those podocytes to allow those proteins to filter through more and then prevent the reuptake of those. What else do we have? Pus, white blood cells, pyorrhea, having a urinary tract infection. And what's cool about taking Bio 130 Lab is you do your urinary test, and I actually had a student who found white blood cells in her urine and went to the doctor to question that because that usually signals a urinary tract infection, and she found out that she actually was asymptomatic for that urinary tract infection, and it was a very progressive urinary tract infection that you have to take antibiotics. So it's pretty good. It's a pretty good thing to get your urine test because you can find things that you don't think you actually have, some abnormalities. Okay, so other abnormalities as well with your hemoglobin and also fine bile. Now, I mentioned earlier that your urine itself is sterile, but what makes it not sterile is bacteria that can be found in it. However, let's think about a situation in which you don't have any water with you. If you're in an extreme situation like this guy over here, he doesn't have any water. Well, of course, that's the least of his problems because he needs to get out of the situation. But can you drink your urine in extreme emergencies? And the answer is yes, you can. And you can actually drink it 1 to 2 times in extreme emergency. Now, let's think about this. So the very first time you drink your urine, you have a lot of water in there, so you can reabsorb a lot of that water in your urine into your body. However, as you continue to drink your urine over time, what's going to happen is that you're going to start utilizing a lot of this glucose to filter out more of that urine than you really need. So you're going to start depleting your glucose stores for energy, which you're going to be needing for other metabolic purposes for your cell function, like your heart rate, your brain function, and so on and so forth. So over time, you're going to end up expending more energy for filtrating your urine than you're going to be needing for expending that energy for more useful resources. So it's okay for drinking urine 1 to 2 times, but anytime over that, you're just going to be wasting energy. Okay, so something to think about. And of course, when you go hiking, don't be crazy and go off path and then find yourself having to drink your urine and wasting energy drinking urine and not getting out of the situation. All right, moving on. Ureters, second organ of the urinary system, and these are going to bring all that urine towards the urinary bladder. It's 10 to 12 inches long, 1/4 of an inch in diameter. So imagine all those kidney stones trying to get through a 1/4 inch diameter. So painful. It's going to enter the posterior aspect of the bladder. Here's the bladder. Posterior aspect is right behind there. Location also retroperitoneal. Meaning it's going to sit behind that parietal peritoneum. And what else? We have peristalsis. That's going to aid gravity in the urine transport. And so sometimes, well, I used to think a long time ago that, well, it's just by gravity. You're going to force urine out. Urine's just going to go from a high level down to here. But no, we actually have that smooth muscles along this ureter that's going to start help propelling that urine down towards your urinary bladder. Urine transport from the kidneys to the bladder is an active process. Okay, so we do need the use of our muscles to bring that urine down. And so imagine that kidney stones too, right? As your muscles contract, it's going to put pressure along those kidney stones and also the walls of your ureter. Painful. Urinary bladder, next organ we have. Main function of this is to act as a temporary storage tank for urine before it leaves into our urethra. We have small valve-like folds of the bladder mucosa, and the function of this is to prevent the backflow of urine into your ureters. And this urinary bladder is composed of a smooth, collapsible muscular sac. And also, one thing to know about the specific type of tissue of this urinary bladder, it's transitional epithelium. Remember, the transitional epithelium, what's the main function of this? It allows stretching and recoiling of the specific organ and tissue type. And so because of that, this can be collapsed when there's no urine found here within our urinary bladder. But the moment that we have urine filling to a urinary bladder, we can start stretching out the entire walls to account for this increase in volume size. We also have this lower region over here called a trigone. And this is a triangular region of the base of the bladder. Let's also look at the 3 different openings of this trigone. We have 2 openings from our ureter. So here's 1 and here's 2. And the third opening is towards our urethra. Okay, looking at this urinary bladder wall, we have 3 layers of smooth muscle that are going to be collectively called the detrusor muscle, we also mentioned already this mucosa is made out of transitional epithelium, and when it's empty and collapsed, how big is this? It's only 2 to 3 inches long. But when it stretches, it's about 5 inches long and can hold up to 500 milliliters of urine. Crazy, huh? So it's about 1 pint. The last organ of the urinary system is the urethra, and the function of this is to carry the urine from the bladder to the outside of the body through peristalsis. So function, carry urine from bladder to outside of body through peristalsis. And we can control the release of this urine by 2 sphincters. We have an internal urethral sphincter, which is involuntary, and made up of what type of muscle do you think if it's involuntary? Good. Smooth muscle. It's also found at this bladder urethral junction. So here is that internal sphincter. And then we have the external urethral sphincter, which is voluntary, which allows you to hold your shishi. And because of that, it's made out of skeletal muscle. And here's that external urethral sphincter. Okay, so first, before we get into how we urinate and controlling our urine and how much urine can fill in our bladder, let's go with the gender differences of the urethra. And so length in females, this is going to be 3 to 4 centimeters long, or about 1 inch. And in males, it's 20 centimeters or 8 inches. Now another thing I want you to notice is the location of males and females. So for females, we have 2 separate structures for reproduction and for urinary system. So the urethra is only for the urinary system. The vagina is only for the reproductive system. Here within the males, the urethra serves 2 functions, both for the reproductive system and for the urinary system. So sperm's going to exit into this urethra, and same passageway for the urine. So in females, the urethra is anterior to the vaginal opening. And in males, it travels through the prostate and the penis. And function in females, it's only going to carry urine. And in males, it carries urine and is a passageway for sperm cells and semen. Now that we have an understanding of the different organs involved in the urinary system, let's go over how we actually shishi. So micturition, which is also known as voiding or urinating. Our bladder is going to collect urine until 250 milliliters of urine have accumulated, and we're going to allow our urinary bladder to start stretching. Remember all that transitional epithelium. So that stretching of the bladder will activate stretch receptors. It's going to send impulses to our spinal cord that are going to bring it back towards the bladder through the pelvic splenic nerve. Now here, this is going to start stimulating the reflex contractions. That's going to cause stored urine force past the internal urethral sphincter into the upper part of the urethra. And this is going to stimulate you and cause you to have the sensation of shishiing or voiding. But if you want to hold it, let's say you're in the middle of an important phone conversation or you're taking an exam and you can't go shishi, then what's going to happen if you don't respond to this signal? You're going to then stop. Those contractions are going to then stop. But of course, your bladder itself is not going to stop accumulating urine. So your blood is still going to start filtering through your kidneys, and more urine is going to start forming. So your bladder is going to continue to fill until 500 milliliters are then stored. And then you're going to have that microturation reflex occur once again. Now, eventually, microturation is going to occur, and why is that? Well, you've passed that urine, the urine has passed through that internal urethral sphincter. Remember, that's all smooth muscles, so you have no control over that. However, because your urinary bladder can only hold 500 milliliters of urine, eventually that's going to put pressure against your external urethral sphincter, and then you're going to eventually voluntarily relax your external urethral sphincter until you void. And that's, of course, when you do the shishi dance, right? Like, ooh, you gotta really go. Okay, so we mentioned earlier that our urinary system can also help maintain our blood composition, and it can do that by our diet, cellular metabolism, and also our urine output. And so we're going to focus on this urine output. So how can we then regulate our blood composition with the use of our urinary system? We can do that through our kidneys. So our kidneys can excrete nitrogen-containing waste, as we already discussed. And these last three we haven't discussed, which we're going to cover right now. So we can maintain water balance of your blood, look at the electrolyte balance of your blood, and also ensure we have proper blood pH, so regulating the amount of hydrogen ions that are in our body, and also we can excrete them. So let's look at the second role the kidneys have in maintaining blood composition, and that's maintaining our water balance. In a normal human body, in young adult females, 50% of our body is composed of water. In males, 60% of that is composed of water. And why is that? A lot of this has to do with an account with our muscle mass. And women, here, they have less muscle compared to men, and they have a larger amount of body fat. So why we also have less water. Babies, 75% of their body is comprised of that water, and in elderly, it's 45%. Now, why is it necessary for us to have water? Well, water is necessary for many body functions, and we need to maintain it. So it's a universal body solvent. We saw that in Chapter 2. Remember, water is used to carry those food particles, solutes, electrolytes, from our blood towards our cells and tissues. It serves in that interstitial space. So lots of functions there. And as we can see here, we see water in three major regions. Intracellular fluid, so this is found inside cells. And it accounts for about 2/3 of our body fluid. And so sometimes people say, oh, I lost a lot of water, I lost a lot of weight in a day or two, but really that's just a lot of this water weight. And it's a loss of that water from your cells itself. You have extracellular fluid. This is found outside of your cells. A couple of examples. You have, well, besides the intracellular fluid, you have blood plasma. You have it in your cerebrospinal fluid. I'm going to shorten that as CSF. You have it in your serous fluids. Remember your synovial joints. You also have it between your parietal and visceral pleura and pericardium. Those humors of your eye. Okay, so a great example of where you would see this. Okay, so intracellular, inside your cells, extracellular, You have it in your blood volume, plasma. You also have it in your interstitial fluid. So interstitial being that space between your cells and your capillary and your vessels. So here's your blood plasma. Everything here, we'll just imagine this being, this is our capillary walls. Here's all the interstitial fluid, and then inside of your cells. Okay, so once again, the importance of this water, being able to carry all these ions from this blood plasma eventually into our cells. In our cells itself, in order for reactions to occur, those hydrolysis reactions, we need to bring in that water, carry things, move things from compartment to compartment. You also need it in that water. You need that water for that. Maintaining water balance. So your water intake must equal water output. And so if not, then you're going to become dehydrated. So average intake per day, where do we get our water sources? You can get it from ingested food and fluids. Also from metabolism. Remember, we also give off water as we break down different processes within our cells. Beverages, this is why it's especially important. We take 60% of our fluid intake from our beverages. Why you also need to take lots of that water. How do we get rid of a lot of this water? Through feces, your sweating, skin and lungs. As you inspire and expire, you're also giving out that water. And of course, majority of that is going to be in the form of your urine. So if we look at what drives us and increases, tells our body to take in water, it's from our thirst mechanism. It's a driving force for water intake. Anytime you have an increase in plasma solute content of 2 to 3%, you're going to excite osmoreceptors found in our hypothalamus. Osmoreceptors, this is going to sense the osmolarity of our plasma solute. So of course, the more concentrated it is, it's going to send off stimulus to this hypothalamus. So let's look at this pathway. If you have an increase of plasma solutes, you don't have a lot of water, you are going to decrease the amount of saliva that you produce, and that's going to give rise to a dry mouth. Having a dry mouth is going to send off signals to this hypothalamic thirst center. It's going to cause you to have a sensation to be thirsty, and therefore you're going to take a drink. Now what happens when you take a drink? You're going to moisten your mouth. Also, when you increase the amount of water into your body, you're going to stretch out your stomach and intestine receptors, absorb a lot of that water into your GI tract, and then after time, your plasma solute concentration is going to decrease. Now this is going to continue. This is going to be a positive feedback mechanism. You want to increase the stimulus until you reach normal levels of plasma solute concentration. And by doing that, eventually you're going to shut off this signal to your hypothalamus that you're still thirsty. Okay, so that's how you can stimulate your body to take in more water. Besides relying on our osmoreceptors for increasing water into our body, we can also regulate water absorption by hormones. There are two hormones that specifically we're going to talk about. We have antidiuretic hormone, and the function of this is to prevent excessive water loss in urine. So we can cause the kidneys collecting ducts to reabsorb more water. It's going to cause an increase in blood pressure and blood volume. So specifically, we're going to increase blood volume first, and then in response to that, we can increase our blood pressure. Diabetes insipidus, this can occur when antidiuretic hormone is not released. This is going to lead to huge amounts of dilute urine and causing the patient to be severely dehydrated and always thirsty. So people who are diabetic do tend to urinate a lot. Another way we can regulate the amount of water in our body is by regulating electrolyte balance. You remember that anytime you have lots of electrolytes, water is also going to follow. So if we increase the amount of electrolytes, we can increase blood volume and increase blood pressure. We can do this by hormones, and the one hormone we're going to look at is aldosterone. And this is going to regulate sodium ions in the extracellular fluid. So sodium is the electrolyte most responsible for osmotic water flows, and this is going to promote reabsorption of sodium ions in the proximal convoluted tubule of the kidneys. And so, of course, we can increase sodium into our bodies and we increase water. Second type of electrolyte reabsorption we have is the renin-angiotensin mechanism. This is mediated by the juxtaglomerular apparatus of the renal tubules, and this is actually found right in the beginning surrounding our glomerulus. So it's found within the afferent, arterial, and some parts of that distal convoluted tubule. And once the cells of this juxtaglomerular apparatus are stimulated by low blood pressure, it's going to release the enzyme renin into the blood. Now, what's the function of this? Once renin is released into the blood, it's going to produce angiotensin II. And angiotensin II is going to cause vasoconstriction and aldosterone release. And what was the function of that aldosterone again? It's going to increase sodium uptake. Remember where we saw that sodium uptake? We saw sodium uptake in that proximal convoluted tubule. By doing that, water is going to follow. And by doing that, you're going to increase blood volume and increase blood pressure. So two different types of systems you should know. Let's look at this overview one more time. You have a decrease of volume within our renal tubules. We can sense that by the juxtaglomerular cells of the kidneys. It's going to release renin, which is going to lead to producing angiotensin II within the blood. That's going to cause the release of aldosterone, which is going to target kidney tubules to reabsorb sodium, increase water reabsorption, increase blood volume, and raise your blood pressure. Also, what we're going to do is cause vasoconstriction of our arterioles to increase peripheral resistance. Other things we can do in response to lowering the blood volume and blood pressure, we can have hypothalamic receptors increase the release of antidiuretic hormone, and in turn we're going to have more water reabsorbed into our body, increased blood volume, and increased blood pressure. Last thing we're going to look at is how the kidneys can maintain acid-base balance. Once again, our blood pH must remain between 7.35 and 7.45 to maintain homeostasis. We have a more alkaline blood pH if it's above 7.45 and a more acidic blood pH if it's below 7.35. And again, why is this so important is because this pH can denature or also change the conformation of our proteins, and that in turn will decrease their functions and then not allow a lot of those metabolic mechanisms to occur. We can also have physiological acidosis, in which case the blood is very acidic, and that's when the pH is between 7 to 7.35. And where exactly do we get all of this acid byproducts? Well, we get them from phosphoric acid, lactic acid, and fatty acids. These can be from byproducts of either metabolism or also just working out, carbon dioxide from carbonic acid, and also ammonia. And we can balance this by our kidneys as well as other acid-base controlling systems within our blood. And so when we look at different ways we can resist these changes in pHs, we look at buffer systems, and these are found within our blood. We have three major systems within our body. We have the protein buffer system. This is found in our extracellular fluid and our intracellular fluid, and this specifically looks at amino acids. Let's look at a couple of problems with aging. So associated problems with aging, we have incontinence, which is a feeling that it's necessary to void. Let's look at a couple of problems associated with aging. The first one is urgency, and this results with a feeling of it that it's necessary to void. Frequency is the frequent voiding of small amounts of urine. Nocturia, so knock, dealing with nighttime, so needing to go to the restroom at night very often. And then finally, we have incontinence, which results of a loss of control of the urine output. And that is the end of chapter 15. I will see you in chapter 16.